Good afternoon. This is Liz Deers, Senior Vice President for Legislative and Regulatory Affairs for the Medical Society of the State of New York, and we'd like to welcome you to MSNY's Advocacy Matters program. This is a monthly program that MSNY sponsors, and it's a series designed to enhance communication with physicians across New York on topical and timely issues of interest to physicians and their patients. We often have elected officials, agency officials, key legislative and agency staff to discuss regulatory and legislative matters. Today's webinar, it will provide you with 1 hour of continuing medical education credit. It will go from 12:30 to 1:30. At the end of the program, you will complete a CME evaluation of today's speaker. The evaluation will be posted at the end of the webinar for each participant to complete. Your CME certificate will be emailed to each of you within the month. You will be muted for the didactic part of the presentation. Save your questions for the Q&A period at the end of the program. For CME accreditation purposes, let me state that neither I nor Mr. O'Leary has a financial interest in any portion of today's program. The program today is entitled Implementation of ISTOP. We are fortunate to be joined by Terence O'Leary, Director of the New York State DOH Bureau of Narcotics Enforcement. Terry O'Leary has been the director of this bureau since November 2011. As director of B&E, he's responsible for overseeing the official prescription program, which supplies over 165 million forms to practitioners throughout the state. He also supervises B&E's prescription monitoring program, which monitors all prescription for controlled substances. The PMP includes the online controlled substance information database, which provides a portion of this data to practitioners through DOH's health commerce system. Terry is here today to talk to you about the implementation of ISTOP and its impact on you and your practice. Terry, thank you again for joining us today. We're very much looking forward to hearing from you.
Thank you very much, Liz, and thank you for everyone who is attending this webinar for the opportunity to present on our progress on ISTOP. So I'm not going to belabor the point because I think many of you may have seen my prior presentations, but just to remind those and inform anyone who may not know why ISTOP came along, this data here is from the Center for Disease Control and Prevention, and it shows that drug-induced deaths and drug poisonings are now the leading cause of unintentional death in the United States, surpassing motor vehicle accidents for the first time ever. And again, the main cause for the increase is overdoses related to opioid analgesic drugs, which is now, overdoses related to opioid analgesics are more than cocaine and heroin combined. In fact, it's almost twice cocaine and heroin combined. But again, this isn't just about opioid analgesics overdoses. About 38,000 drug overdose deaths in 2010, and almost 58% of those involved pharmaceutical drugs. Many involved multiple pharmaceutical drugs. As you see, opioids were involved in about 75% of all pharmaceutical overdoses, but benzodiazepines were involved in almost 30% of drug overdoses. New York City Department of Health recently put out an epi-data brief which showed that half of all pharmaceutical overdoses in New York City involved benzodiazepines. And you also see other drugs such as antidepressants, anti-epileptic drugs also involved. So this increase in drug overdose deaths, which has been classified by the CDC as an epidemic, in part led to the prescription drug reform law, the first part of which is ISTOP, which updates New York's prescription monitoring program. The second part is a shift to electronic prescribing. New York's official prescription program is moving to an electronic prescribing program with certain exceptions. We made changes to the controlled substance schedule. Most notable was the movement of hydrocodone in all formulations from Schedule 3 to Schedule 2, something that the FDA is now actively considering, and an expert panel actually just recommended back in January or February that the FDA move hydrocodone to Schedule 2. Hydrocodone is the most prescribed drug in New York State. It over 4 million prescriptions each of the last 4 years, although we did see a marked decrease in the prescribing rate following the June announcement of the ISTOP law. The movement to Schedule 2 went into effect on February 23rd of this year. There was a work group that was put together, which there were members, stakeholders from practitioner groups, including MSNY. There were pharmacists, consumer advocates, and law enforcement agents who participated as well. And that work group very recently finalized, and they will shortly be published, their recommendations on continuing education. They are recommending that the Department of Health mandate continuing education in the field of pain management, addiction, and controlled substance prescribing, although I will note there was vigorous dissent, including dissent from MSNY's representative on the group. And finally, a safe disposal program. Over 3/4 of the drugs that are abused by someone other than to whom they were prescribed. And the state has rolled out a safe disposal program. We now have over 55 drop boxes located throughout the state. If you go to nyhealth.gov, you can put in medication drop box, and an interactive map will come up. One thing I will encourage any practitioner who's listening to do is when you prescribe a controlled substance or any drugs, actually print out a list of the drop boxes in your area and give them to the patients, or tell the patients where to find this information. It's an environmentally friendly way to get rid of unwanted and expired medications. So now to ISTOP. The first part of the bill required the department to update our PMP, and we've been doing that since the bill was announced back in June. It requires that more timely data be submitted to the PMP by the pharmacies. It requires that we make additional data available to the practitioners who are using the system, and it also allows us to share information with additional appropriate entities. Most importantly for my audience today is that you can have a designee, a non-clinical, non-licensed staff, look up this information for you, so long as they are trained in all relevant federal and state privacy statutes. So the big part of ISTOP is the duty to consult. And beginning on August 27th of this year, practitioners, before prescribing a Schedule 2, 3, or 4 with limited exceptions, must consult the registry to view their patient's controlled substance history. What the law actually requires is the person who is making the prescribing decision consider their patient's information in the registry in determining whether or not a prescription for a controlled substance is appropriate. You do not have to be the one to access the registry. Designees will be able to get the information for you and share it with you. You can print it out the day before. The regulations have already been filed with the Department of State. They should be in the state register either next week or the week after. They're going to indicate that practitioners can access this information up to 24 hours beforehand. You do not have to interrupt the patient's visit to consider this information. You can print out this information and access this information for any patient who is under your treatment. You are not limited to only the act of prescribing, so you can print out your entire patient roster the night before or the morning of, whether or not you think you're going to be prescribing a controlled substance. So it's important that everyone who is going to be prescribing controlled substances and anyone who you think will be accessing the system on your behalf get a Health Commerce System account immediately. Over half of the practitioners in the state who can prescribe controlled substances already have accounts. In any given week, the number of prescribers and practitioners coming on board is going up at an increasing rate, but we still do not have 100% participation. The web address there is how you sign up for an account if you don't already have one, if you're a practitioner. Below that, you can see you can have your HCS director or coordinator through the same web address access information and sign up non-licensed professionals. The Bureau of Narcotic Enforcement has provided a tool on how to walk through and sign up to MSNY, and I do know that Pat Clancy sent out emails to a number of people with information on how to sign up both licensed professionals and unlicensed professionals. But it's very important that you sign up as soon as possible. You don't want to be caught in a rush in August. So once you sign up and you have a Health Commerce System account, this is what you see. This is the front page of the Health Commerce System. You put in your user ID and your password. If you haven't used your account for over 90 days, you're going to have to contact the HCS to reset your password. That process has been streamlined. We're also streamlining the sign-up process as well in an effort to make it more user-friendly and to lessen the burden on practitioners and their designees using the system. Now, when you click through and you enter into the HCS, you're going to see this logo in the middle of the page. It's not going to be that large, but it's going to be right there. If you click on this logo, it is going to take you to the PMP automatically. You don't have to go into the alphabetized lists to try and find the name of the application. Just click on this button, and it's going to take you to this page. This page, the first time you enter into the PMP, you're going to have to click on an attestation. But unlike the current PMP, you do not have to click on the attestation each and every time thereafter. You just need to do it the first time you enter into the PMP. And that's the first time after the new system is up. So it's not each and every visit. It's just once for the duration of your account. So the information you see here on the screen, this is the default page, and this is where you will put in your patient's information. So you'll put in your patient's first name, last name, their gender, and their date of birth as best as you know. You will then be asked to attest to the guidelines as you did your first visit, and if you want to go back and revisit them, you'll see at the top, right under patient search, it says click here to review the guidelines to let you know. Once you have entered in the patient information, you click yes. You get this page, which will show you the search information you entered in. Here it's Jack Spratt, male with a date of birth of January 1st, 1970. And you can either continue, and this will conduct the search, or you can go back if you've misentered the information. This is the information that will come up in the form that it will come up for your search returns. You'll notice at the top next to search terms, it says Jack Spratt, male, date of birth. And next to it, it says search date. This is the time at which you or your designee actually searched the database. Below that, you will see information, and it'll say data detail level. Printer friendly, which is what is clicked right here, will give you this information. And the information you see is the date the prescription was written. First off, it's separated into two separate groups. At top, you see My Prescriptions. Once you enter into the system, you want to associate your DEA number with the search, and I'll show you later how to do that. It will return any prescriptions associated with your DEA numbers, and you'll see that Jack Spratt is actually broken into two separate groups here. One is Jack Spratt with a date of birth of January 1st, 1970, and the second grouping under My Prescriptions is Jack Spratt with a date of birth of January 2nd. We return similar results and allow the practitioner to make the decision whether or not this is in fact the same individual. One additional piece of information that we've shared with you that was not in the prior PMP is the patient's home address. There's a Terence O'Leary who lives in Murray Hill in Manhattan. I don't know his date of birth, but if it's similar to mine, you very well may get both of our information returned. This will give you an additional piece of information to tell you whether or not it is the same person. What we tell people using this information is the information is only as good as what we receive from the pharmacies. We receive over 24 million records a year, and we can independently verify each and every record. We do have a very low critical error rate, reporting rate. Our pharmacies do a very good job of reporting information to us, but it is not foolproof. And the person writing the prescription, part of their clinical judgment is going to have to be to determine whether or not it is actually the same person. So you see below, you see others prescriptions. And again, this is Jack Spratt with a date of birth of January 1st, 1970, and a similar address. At this point, you now have this information, and when you're going to consider whether or not you want to prescribe to Jack Spratt, you have his controlled substance history for the last 6 months, regardless of how many prescriptions he filled. So if someone received only one prescription, you will receive that information, unlike what you receive in the current PMP. So at the top, next to data detail level, there's an extended button. And if you click on that extended button, we'll give you additional information that you didn't have access to before. What shows here is DEA number, payment method, and dispenser. I can tell you DEA number actually will not be provided for security purposes. We don't want to be sharing the DEA number. This was an old mock-up, and I apologize for that. But next to it, you see payment method. This will tell you if your patient, is paying with insurance, paying with Medicaid, paying with cash, or paying with a separate type of government insurance, such as military. This is very important for people who are engaged in pain management. A standard clause in narcotic or pain agreements are that if you have insurance, you must pay with only insurance. And the next field to the right, you see dispenser. What this will tell you is the pharmacy or the dispenser at which the drugs were actually dispensed, which is also important, as you know, because another clause in these narcotic or pain agreements is often that you have to go to one pharmacy and one pharmacy only. Going to multiple pharmacies can be indicia of doctor shopping or fraud and deceit, although there are very often legitimate reasons for it as well. We think this information gives a prescribing practitioner who may have pause about prescribing and concerns about their patient's activities a couple pieces of information with which to discuss with their patient. So the next slide, as I told you, if you don't enter your DEA numbers in, even if you have written a prescription to Jack Spratt in this instance, but you did not associate your DEA number with your HCS account, you will not see the prescriptions attributed to you. They will just say other prescribers. And what you in fact would see under prescriber name is your own name if you wrote under your DEA number and not an institution DEA. So what you see here are a couple of things. One, if you enter in a patient's information and that patient has not received a controlled substance prescription in New York State in the last 6 months, it will actually tell you that there are no results for the search terms that you entered. So this way you can print this out for your records, or we also log these in the Department of Health. So we know you did the search and we know that no returns were, no results were returned to you. But if you look directly under the NYSPMP logo, you see 3 listings. One is patient search. If you click on patient search, that will take you to the initial page where you put in the patient's information. The next is drug listing. What we've done is we've listed common brand names associated with the active drug. For instance, for hydrocodone, it would be Norco or Lortab or Vicodin. And then next to that is My DEA Numbers. And this is where you can go in and enter in your DEA numbers. You click on that button and it will call up this screen, which shows you where you enter your DEA number. Now, under the law, you can only enter your own DEA numbers. You cannot enter someone else's DEA numbers for them and check their history. That would be a misdemeanor under violation of 3371 of the public health law, and we do have a hard stop-in to try to stop that, and we do audit that as well. But if you have multiple DEA numbers, as many prescribers do, you can consolidate them here so that all of your prescriptions will show at one single time. Now, I mentioned the drug listing. If you click on drug listing heading, this is what will return, and so you can see for alprazolam, it gives you the brand name of Xanax. It will also tell you what schedule it is in New York State schedule, which is important because remember the duty to consult only relates to schedules 2, 3, and 4. It does not include schedule 5s, and it will also tell you if you can write refills for these specific substances. Now what you see here is the help page. If you look underneath where it says welcome Kevin D. Johnson, who is the person who logged into the PMP here, you see update your personal info, you see frequently asked questions, and you also see the help button. You can use this to update your personal information and your professional license information within the health commerce system. The frequently asked questions has an updated PDF of questions surrounding the use of this information, where it's collected and what it's to be used for. These are FAQs, which we will be updating as we receive questions that we didn't address, or if it includes answers that are either not clear or not needed. And to the right, you see the help button, and it gives you a couple of different options. One is if you're experiencing difficulties using the actual application, you can either call that number or you can click to send an email directly to B&E. And below that, if you have concerns about your patient abusing controlled substances, you can contact OASAS for a referral, and it will have a phone number, and it has a link to OASAS's website as well. Excuse me. Finally, and the next slide, if you look up at the top under the logo, the NYSPMP logo, you see the yellow banner application that's right there. And what this banner does is it gives the Bureau of Narcotic Enforcement the ability to put out notifications, and we can update this very easily and on a daily basis. And in this instance, it indicates that the PMP application will be down for an hour Wednesday, May 29th, which was in the past. But we can put out other information as well and disseminate it to a very wide audience as is appropriate. So a few of the other things I went through already. The update personal info link that was on the top of the page, it takes you to the HCS application, and it will allow you to keep your license information up to date. You don't have to go out of the HCS, and there's a direct link to do that. The FAQ link that was there opens the PDF that I discussed. We'll be able to update that on a weekly basis as questions come in. If there are questions that are being asked and we see they are not answered in the FAQ, we will address that. Excuse me. As I mentioned, we'll be able to put in system alert messages to get out to every practitioner or their designees that may be accessing the system. And finally, you see that the current time and date at the moment the page was loaded is there, so that if you print this out, you have for your own records at the time that the search was done. So these are the functions. The PMP is being rolled out in phases, and the functions that I just went through are all available in phase 1, which will be available to practitioners by early next week, if not before then. We've been running it internally within the Department of Health with great success. It works pretty quickly. We actually do it by accessing through outside lines as well. I've been running searches on my own, and from login to when patient information is presented to me, it takes anywhere from 30 to 45 seconds. It's been returning patient information in under 3 seconds from when you hit search to when the results appear on the screen. There will be additional functions which will be rolled out, and phase 2 and phase 3 that you see here will all be available before August 27th. Most importantly is phase 2, which will be in July, is the ability to assign designees, to go in and to sign up individuals who you want to look up this information on your behalf. As I mentioned, the regulations have been filed with the Department of State, but they have not yet been put in the state register. Until they are enacted, you will not be able to actually designate an individual. There needs to be a regulation governing that. But you will be able to to sign them up and get them in the system and link them to your account so that when the regulations are adopted, they can do the searches for you. Phase 3, which will be rolled out in early August, will allow for searches by pharmacists and designees. It will allow individuals to do bulk searches, so you can look up multiple patients at a given time. You don't have to go back to the patient search page for each individual patient. And we'll also produce practitioner reports so that once you've consolidated your DEA numbers, you can go in and see what has been dispensed on your DEA numbers. And this is important, one, to allow you to audit your own prescribing history to see what you've prescribed and to update your medical records as is appropriate. But it will also let you know if someone is misusing your DEA number or if by chance someone has taken your official prescription paper and is writing prescriptions under your DEA number with your prescription paper. We find that those are two types of crimes that we often find out about when we send doctor shopping letters to prescribers who have prescribed to a doctor shopper. We'll find out that, one, it was a former patient who is using their DEA inappropriately as a form of identity theft, or two, they've lost their paper. A couple of other things that we're doing that may not directly relate to this audience is we're working with the pharmacies. Something to keep in mind is that pharmacies have traditionally reported to us once a month. That's it. They are now going to have to report to us every 24 hours. So once the drugs are handed over to the patient, they have 24 hours to report that record to us. So what we're doing is we're allowing them to upload in batch format much more easily than they do now. They can either enter it manually or they can go through the Department of Health's unattended data collection system, UPHN Lite, which currently collects data in an unattended fashion and secure fashion. Another thing it allows is for zero reporting from pharmacies. If they do not fill, this will let the department know that they are actually operating but not filling controlled substances at that time. This way people don't fall off our radar by not reporting. And finally, they'll be able to correct their own submissions excuse me, they'll be able to correct their own submissions online, something that currently we use a very antiquated system of faxing errors to people and talking with them on the phone. So updates on electronic prescribing. Electronic prescribing is now permissible in New York State. If you have met the DEA's rule, you're using a DEA-approved application, and you are in fact undergone identity proofing and have your 2 factors, you can e-prescribe once you have given a notice of the application you're using to the Bureau of Narcotic Enforcement. You can do that by emailing us. My email information will be on the next slide. You can also do that through the PMP. We have talked with a few practitioners and several pharmacies who are ready to start e-prescribing, and what we're doing is going through their audit process and making sure that we had no questions. And I'll say it's going very smoothly. We haven't heard any complaints yet to our face, and we think that e-prescribing is going to pick up some momentum once we actually have both prescribers and pharmacies on board. This has always been a chicken and the egg problem. One wasn't doing it because the other one wasn't, and no one was willing to break the ice. So obviously what I think partially broke the ice is the requirement that on March 27th, 2015, New York State's official prescription program with paper is moving to e-prescribing. There are limited exceptions which speak to patient safety, prescriptions going out of state, a proactive waiver granted by the Department of Health. But aside from that, it will be mandatory. You can go to the state register or go to the homepage of nyhealth.gov and look up recent laws to read through our regulations. I will say we have, my bureau has put out 4 separate regulation packages in the last 3 months. There's e-prescribing, there's a use of prescription forms for limited English proficient patients. In last week's state register, we put out regulations to address inconsistencies in the law with needles and syringes. And as I said, the ISTOP PMP regulations were filed with the Department of State and should be in either next week or the week after state register. They will be out for 45-day comment, and we look forward to people reading them carefully and submitting well-thought comments. So finally, this is my web page. Go to the web page. We've updated it. We are going to be updating it much more frequently. It'll give you information on e-prescribing. It will give you information on official prescription program. We're going to be putting up the FAQs separately from the PMP, but I'll remind you all of this is going to be accessible through the PMP right now. It'll give you information on where to find HCS sign-up, and not to put them out, but I will mention that Ms. Nee again has sent out information on how to sign up both licensed and unlicensed professionals. We worked with Pat and Liz to make sure that it's guidance that will be responsive to the questions that have been coming in from you, the practitioners. With that being said, I'm going to pass the mouse back to Miriam.
Well, thanks, Terry, for a really comprehensive and helpful presentation. We wanted to leave as much time as possible for Q&A because I know we have an awful lot of people on the line and that they must have a lot of questions. So to ask a question, you may either raise your hand located in the box to the right of the PowerPoint or send us a question via the chat. Please remember to put your hand back down when your question is being answered. I believe I have one question here in our office, and then we're going on to the other questions from you.
Actually, some of these questions came in because the physicians couldn't be online today. The question is, if an ER physician wants to order more than a 4-day supply of controlled substances, does he or she then have to take or check the PMP?
Yes. So it's more than a 5-day supply.
Yes.
They can write the
Right.
5-day supply, but if they're going to prescribe more than a 5-day supply, they will have to check the PMP.
All right. Now,
Or someone. And one thing I'll say is,
to.
when we've been talking with some of the institutions and with the associations that represent the institutions, we've been encouraging them to try to incorporate this workflow with an administrative staff. Now, they have the choice of having the practitioner or designating residents to check, or any individual, but at some point a medical record of some type is compiled or retrieved. And we've been encouraging the institutions to, or letting them know that they can do this at the point when the patient comes in, when all of the other perfunctory questions are asked. When they do the other checks, they can put in the patient's information and get the record at that point.
And then I have a follow-up, is the physician's obligation upon discharge of a patient from the hospital with a prescription for a controlled substance. Do he or she have to check the PMP?
They do, and I do know there was a presentation where I think someone from the department, there was a little bit of confusion on that. That is not an exception. If the exception for institutional dispensers are if they're being prescribed for use within the institutional dispenser. So if it's being prescribed, usually in order, but if it's being prescribed for use within a hospital or within a nursing home that has an institutional dispenser license from the Bureau of Narcotic Enforcement, you do not have to check. But if any portion of that prescription is intended to be used off the premises, they will have to check. And so obviously the discharged patient, it's entirely used off of the premises.
Okay, so one of the chat questions is from an office manager that would be the designee for the office. There are 4 doctors in the office. Does that office manager have a problem being the designee for all doctors?
There's no limitation in either the law or in our programming. Whether it's a problem within your office, I don't know, not to be glib, but the doctors will be able to, any practitioner will be able to designate as many individuals as they feel is appropriate. So they can designate one individual. The same individual can be designated 1 time, 100 times, 500 times. Something to keep in mind is the individual who is going to be designated needs to be trained in relevant federal and state privacy statutes. Essentially, if they are HIPAA trained and HIPAA compliant, that would most certainly address the concerns. But the person who designates is actually strictly liable for the misuse of information, which will probably be what curbs the number of designees. So a doctor or a prescriber would not want to designate 500 people because they're going to be responsible for all 500 people's access. So in your scenario where 4 doctors had designated you, and I anticipate we'll do another webinar when Phase 3 is rolled out, what you'll see is when you log in, if you are not a prescriber, you will not be able to run a patient search. There will be an additional field, and in that field there will be a drop-down menu. And it will put each of the 4 doctors, assuming you've been designated by them, it will put each of their names there, and you will choose which doctor you're doing the search for. And then when you do the search, the information that will come back, you looked up Jack Spratt, questioner's name is the person who did the search, and there will be an additional field that will say, on behalf of designating doctor. So this way that both the practitioner, the designee, and the Department of Health can all track who did the search at what time and on whose behalf. And one of the additional functions that will be given to practitioners will be that they can go in and audit their designees' searches without having to call the Department of Health. There will be another button where they can go in and see that designee 1 looked up these individuals under my name at this time, designee 2 looked up these individuals, which will be a good way to check to see if your designees are looking up all your patients and your next door neighbor or the New York Yankees to be able to audit. So you won't have to contact the Department of Health for that. Practitioners will be able to audit their designees' searches on their own.
How long will that data be reposed in their database?
So it's going to start off at 6 months, but obviously since we don't have any historical data because designees don't have access, on day 2 we're going to have a day's worth, and day 3 will, so it will build up over time. Right now the data on the patient's information is already populated, and we're allowed to keep by law up to 50 months of patient identifying data. That's what we have, and we're going to be presenting starting next week 6 months, and it's eventually going to build up to the statutory limit.
Okay. So can Suboxone be e-prescribed at this time?
Well,
e-prescribing reg is out.
The e-prescribing reg is out, and
the question is whether they have a certified e-prescribing system.
Correct. So I am not, and I always get one question I'm not definitive on. I'm not aware of any special requirements either by the DEA or the Office of the National Coordinator for the prescribing of Suboxone or any other buprenorphine product versus other controlled substances. So what you need is you need a DEA-approved application. And what we found are the people who provide these applications, the vendors, actually do the identity proofing for you. So it's incorporated when you sign up for their e-prescribing of controlled substance application. They will go through the steps of making sure that you are appropriately identity proofed by the DEA. They then provide you with your token and your password that you use to e-prescribe.
Right. Okay. So now we're going to go to the line. Ann Nafsinger. Dr. Nafsinger, your line is now open.
Thank you. I have 3 quick questions.
Yeah, Doctor, we can't, there's an awful lot of feedback. Could you type up that and ask that when we receive them? So we'll go to the next chat question we've received. Can you review, just to be certain, providers, prescribers have a duty to consult the registry, but not a duty to report their prescription that's done at the time of dispensing by the pharmacist. Is that correct?
That is correct. So the original draft of ISTOP required that practitioners enter in prescribing information into an application that was separate from e-prescribing. That is not a part of the law. So you fill out the prescription form the same way you do now. There's no requirement that you document the check of the PMP on the prescription form. The pharmacists are not going to be put in a position where they need to police whether or not the prescriber actually checked the PMP. They will have their own access, and the pharmacies still report this data to the Department of Health. What changes for them is the time frame in which they report. We've gone from monthly to daily.
Okay, great. So after you check what happened, or can you review the exceptions, please?
So I'm going to do this off the top of my head, but the first is an exception and a preclusion, and that's veterinarians. This is a database of human beings. It's out of the scope of practice for them to check. If they have concerns about the owner of an animal to which they're prescribing, they need to contact the Bureau of Narcotic Enforcement and report that suspicious controlled substance activity. The second one is if the controlled substance is being administered to the patient, if it's an administration as opposed to it being dispensed, that's an exception. If it's being prescribed for use within an institutional dispenser, and so I see another question is whether it's a Class 3 and Class 3A institutional dispensers. If you have an institutional dispenser license, which originates under Public Health Law Section 3342, and that is the enabling statute for all of B&E's institutional dispenser licenses, including institutional dispenser limited. You are exempt if the prescription is for use on the premises. So if it's a discharged patient, if it's someone within a nursing home where there's a therapeutic leave anticipated during the life of the prescription, then you cannot use that exception. It's only if the drugs are going to be consumed entirely on the premises of the institutional dispenser. Other exceptions include if your patient has been admitted to hospice as defined in Section 4002 of the Public Health Law, if it's a 5-day supply and it's being prescribed within an emergency department attached to a general hospital. We do have a standalone ED now in New York State, and there are a number of, obviously, urgent care centers. They cannot avail themselves of that 5-day exception. There are 2 catch-alls. One is if the practitioner's circumstances preclude him or her from accessing the system or having someone access the system on their behalf in a timely fashion, and the delay would unnecessarily impact the patient's medical condition. And then there's a similar one where it's the patient's medical condition is the driving factor, not the practitioner access. There's also a proactive waiver if you can demonstrate technological limitations which would preclude you from accessing this system as a matter of course in your practice. Pat, did I miss one? I feel like I missed one.
I will say the information on the ISTOP law and the exemptions are posted on the MSNY website under the ISTOP information, and it's www.msny.org.
I should also like to add that copies of, we're getting a lot of the same questions, copies of this PowerPoint and this entire program actually will also be posted on MSNY's website, www.msny.org. Next question from Ann Nassinger. I know there were three. Thanks for writing in. Is there another way to search for patients with hyphenated last names? There's some inconsistency about how the names are entered, and it can be difficult to find the records.
So one of the things that we do on an ongoing basis, and have done for the last 3.5 years since the system's been up, is constantly revisiting the algorithm on what information do we present, do we return. And a couple of the things we take into account are that pharmacies will enter in last names. They will sometimes drop one of the hyphenated names, and sometimes they choose the first name, sometimes they choose the last name, sometimes they combine them into one name. We work with the pharmacies to try to get them to enter it as the prescriber has written the name, and if it's part of their policy to verify with identification, although there's no legal requirement that they ask for a patient's identification. We think that we've addressed that, that we account for hyphens being dropped or included. I can tell you, as someone with an apostrophe in my last name, it can be absolutely infuriating the way they get included and don't get included. DMV refuses to recognize the fact that I have an apostrophe in my last name. But we try to account for that. I'm not going to tell you, though, that it's 100% foolproof. We had this discussion last week. We reached out to the pharmacy societies to try and standardize their reporting. And we do think the system is better, but again, it's not foolproof. Something to keep in mind, something that I know MSNY actively lobbied for and that is included in the bill, is that if the information that is presented to you, if you do a reasonable search and the information that is presented to you is faulty, that the practitioner does have immunity based upon incorrect, incomplete information that was provided by the Department of Health, which I think in part gets to the hyphenated question and other similar differences you'll see in names.
So how do we document that we checked the PMP? Do your audit records suffice?
Well, the regulations which will be out are going to speak to what needs to be documented and what doesn't. Article 33 and Part 80 of the health regs require that a record be made about a prescribing event when you choose to prescribe. The regs aren't going to specifically say that you need to check the PMP. The regulations, or that you need to document that you check the PMP. The regs will require that if you either don't check because of the practitioner's circumstances or you didn't check because of the patient's medical condition, that some documentation as to the specific circumstances that precluded you from checking be documented. But other than that, there is no requirement. As a former litigator, not as an employee of the Department of Health, I would say I don't know why you wouldn't want to document that. You never know who's going to come and ask whether or not you checked. We do have access to those audit records. We cannot share that with you based upon a FOIL request, and we can't share that with you based upon a subpoena or court order in a civil case because it obviously includes patient identifying information. So a practitioner's ability to get that information from the Department of Health is going to be limited by 3371 of the Public Health Law. So if you want it, we're going to give it to you as a function. As I said before, you can search your own audit. You can audit your own searches or your designees, but I don't know the harm in printing it out or storing it electronically as well if it fits with your workflow.
Robert Shaw, we're opening your line. Please ask your question. Dr. Shaw? Robert Shaw? Are you still with us?
I am here. I believe you answered my question already. Thank you.
Okay, very good. So one question on the chat, how do I know if my e-prescribing application is certified?
If you're asking, it probably is not. So most of the e-prescribing applications out there only address the e-prescribing of non-controls, which is different from the e-prescribing of controls. The DEA issued a rule in March 2010, and which it adopted in collaboration with the Office of the National Coordinator. They certify whether or not applications have met their security standards. I believe there are about 11 or 12 off-the-shelf products right now, and not to be an advertisement, but if you go to SureScript's website, they will give you the names of them. Some of them are actually incorporated into EMRs, some are not, and there's a range of capabilities that they give. We've talked to many, if not all of those vendors to see what they offer to practitioners and to make sure that their applications are actually certified. What we would expect of you is that you used application number 1 that had been certified by the DEA, and that's not a real name. You would just tell us that I, practitioner, am using application number 1. And this way the Department of Health now knows, and we have a record of what your application is, that it meets DEA requirements, and that the security concerns are appropriately addressed.
So to be sure I understand, there's no prescription information that the prescriber inputs into the system at the time of prescription?
That's correct.
How will the state audit practitioners to be sure that they're complying with the law?
Well, I'm not going to tell you how we're going to catch you, because then everyone just takes a step to the right. But we will have multiple audit trails. We're going to be able to tell. We currently use this information to start investigations now. We do it at an increasing level based upon data searches on our own. And a few ways that we can track are, 1, DEA numbers, official prescription serial numbers, pharmacies, and we can also track patients. So we have a number of different audit trails, a number of different points of data that we can compare. And with overhauling the PMP, we're also updating and drastically increasing our ability to data mine this information to start investigations.
Okay, so what are the expectations for opioid treatment programs who prescribe and dispense methadone when patients are receiving take-home doses?
And that was the exception I couldn't remember. So thank you for that question. This is an exception as well. So in our PMP, we actually collect dispensing information on methadone. However, we are not allowed to share that information. The CFR precludes us from sharing information based upon methadone that's being dispensed for the treatment of addiction. So if you are prescribing or dispensing methadone for the treatment of addiction, you do not have to check the PMP. Now, obviously, methadone can have dangerous drug and drug interactions. If the patient is under your treatment and care, you can check. You're not precluded from checking, but you are not required to check. And part of that is to be consistent with the fact that the patient's information about dispensed methadone for addiction treatment will not be contained in the PMP. Now, methadone is increasingly being used to treat pain. If you are prescribing or dispensing methadone for the treatment of pain, you have to check the PMP. It's the prescribing or dispensing of methadone for addiction, which is an exception to the law.
So do the rules you discussed apply to children?
Yes.
Would a physician receiving a call after hours for a narcotic fall under the preclusion of inability to access the system?
I'm not going to give an answer to that, and I can tell you there would be a number of questions that I would ask. I would say, well, you got the call. Was it a smartphone that had internet capability? Were you at a computer terminal? Were you able to call somebody at an institution or at a practice who could check for you? It's going to come down to whether or not the decision to avail yourself of that exception is reasonable. And for me to give an example right now wouldn't be the best idea. While I helped in writing the law and implementing the law, I'm not going to be the judge of whether or not the law was violated. And I wouldn't want to give anyone false hope that something is included or not included. It's going to depend on whether or not it's reasonable, and that is one reason why the regulations are going to require that in your circumstance you document in your medical record why you couldn't do the check. With all the smartphones and easy access to technology nowadays, I think that exception is going to become more and more out of the ordinary course of business, and will be used less and less than even what was anticipated a year ago.
Is there, and this goes to the issue of the designated office staff, is there a certain level of access that designated office staff member needs to have?
So what will happen, and again, this will be more appropriately addressed down the road, most importantly, sign anybody up for an HCS account as soon as possible. I know HCS has been telling people that they're going to expedite the sign-up process, and what they have proposed is very encouraging. I don't know when the rollout date for that is, though, so I wouldn't suggest that you wait. Once designees are in the system, the regulations are going to require that the person who designates them either trained or knows that the designee was trained in all relevant federal and state privacy statutes. So that's going to be HIPAA, high-tech, and for our purposes, the Patient Privacy Act, as well as 3371 of the Public Health Law. So if you either trained them or you know somebody else did, you can designate them. There does need to be some type of relationship between the designee and the employer, so you can't train a call center overseas to do this for you. The person needs to be within New York State, and the regulations you'll see are, it's pretty broad, but it does establish that there needs to be some type of actual existing relationship between the practitioner and the designee. We don't want to create a business for people to be data mining individuals' personal patient records. But once the regulations are out, you'll be able to read them and submit public comment.
Okay, so do these regulations apply to other Schedule III drugs, such as testosterone?
Yes.
If a hospital attending MD writes on discharge, not in the ER, a script for a controlled drug for 5 days or less, must they check the system?
Yes.
Okay, so we've gone through all of our chat questions. If anyone has any further questions, we'd be happy to entertain those. So, okay, well, again, I'd like to thank you, Terry O'Leary, for participating this afternoon. We are going to start our evaluation now. We urge all who attended to please take the next 4 minutes to complete the evaluation. Our next program will be held on July 9th. Program to be decided. Thank you all for attending.
There's also additional webinars on ISTOP implementation June 19th at from 6 to 7:30 p.m. Mr. O'Leary will again serve as our faculty. And then there's also a July date to be determined, same time, same place, and you can register for this program, the June 19th program, at MISNY.webex.com, and Miriam just highlighted it in red. So,
but remember, we have limited seats.
Yes.
So what we would encourage you to do is to encourage your colleagues to sign up for these June and July programs now that you've taken it, and you will have ready access to the PowerPoint through the MISNY website. Thank you again.